morning. I'd like to thank the CCF and Kim Lin for inviting me to talk. It's nice to see some familiar faces in the crowd, and as well as some new faces as well. I'm here to talk about the medical and surgical management of heart failure with a pediatric focus. I'm also trying to take the so-called mile-high view. Some of the talks earlier this morning really got into the details. I'll be a little bit less detail-oriented and more of the spirit of, what are the doctors thinking when they leave the exam room and go back and talk about their patients to the nurse practitioner, to the residents and the medical students about this patient and how we approach heart failure, hopefully to get you as patients and families a bit more insight into how we think and approach heart failure. So I'm going to go over by defining what is heart failure, how do we characterize its severity, what are the common presentations of heart failure in children, and some broad strokes about the medical, surgical, and device therapy of heart failure in children, and finally just a few snippets of, I think, exciting developments that were already brought up by Kim, Joe, and Anjali earlier this morning. So the American Heart Association defines heart failure in the following sentence. It is a complex clinical syndrome that results from any functional or structural impairment of ventricular filling or ejection of blood. And everything, how we define and treat heart failure somewhat derives from that statement. I think very importantly, however, given that this is a cardiomyopathy conference, it's very important to recognize that cardiomyopathy does not necessarily equal heart failure. Heart failure may be a consequence of cardiomyopathy, but not every patient with cardiomyopathy has heart failure or will develop heart failure. We use the echo a lot in heart failure because it's a very obvious, quick test. We're visual people. But heart failure can be present in patients who have, on the left, very impaired heart function. This is a dilated left ventricle. It's not squeezing well. The right ventricle is also impaired here. Yeah, you have a patient on the right who has a diagnosis of restrictive cardiomyopathy, whose heart squeezes quite well, but has similarly severe heart failure. So as part of this talk, hopefully I will kind of define how patients with seemingly quite disparate echocardiograms and diagnoses can have a unifying diagnosis of heart failure. So just some key points regarding the definition of heart failure. There is no single diagnostic test. We still rely as physicians and other practitioners on the physical examination and the history more than any single test, echo, BNP, MRI. Heart failure may result from inadequate ejection of blood from the heart. We usually call this systolic heart failure or heart failure with depressed or reduced ejection fraction. Impaired filling of the heart, sometimes referred as diastolic dysfunction, or more in the adult literature, heart failure with preserved ejection fraction. However, a combination of both can be present in the same patient. This is very common in restrictive cardiomyopathies, for example. And the causes are quite diverse, particularly in children, which is, let's see if the slide will advance here. There you go. So this is just a very broad simplification of the various causes of heart failure in children. One of the things that makes this job very interesting is that we get to think about the numerous causes of cardiomyopathy in children, but it can also be challenging for the patient and the family because oftentimes many different tests and tests over a prolonged period of time can be required. These are the common causes. Dilated cardiomyopathy, idiopathic, familial, acquired from toxins such as chemotherapy, metabolic conditions, inborn errors of metabolism, for example, or mitochondrial disorders may all lead to a dilated cardiomyopathy. Myocarditis, or inflammation of the heart muscle, from, again, a whole myriad of etiologies or causes that are too broad to list here. Left ventricular non-compaction is a common cause of heart failure. We see heart failure in congenital heart disease, whether it's preoperatively or as a result of the various operations that children will go through, may result in heart failure symptomatology. And there are less common causes that some of you are certainly familiar with. Arrhythmias may result in cardiomyopathies that lead to heart failure. Hypertrophic cardiomyopathy classically does not result in heart failure. Patients with hypertrophic cardiomyopathy usually have preserved systolic function, but have unique problems of their own that may result in heart failure. Restrictive cardiomyopathy is an uncommon cause of heart failure, and typically is not the presenting symptom in those patients. How do we characterize heart failure severity? I'm sure many of you are familiar with the NYHA, or New York Heart Association, classes of heart failure. Class 1, 2, 3, and 4. It's very easy to understand. Class 1 are patients who are asymptomatic, and as you escalate through the classes to Class 4, which are patients who are symptomatic from heart failure at rest. These are not particularly pediatric friendly in that they are mostly focused on activity and exercise, and so particularly for infants and toddlers may not be appropriate. There is the Ross classification, which takes the same Class 1, 2, 3, and 4 that you have for NYHA, but adds some more particularly infant-specific symptoms, tachypnea, diaphoresis, or sweating related to feeding, which is the primary activity of many infants, obviously. The Class 3 heart failure stresses the importance of growth failure, which is an important characteristic of children, of course. And then Class 4 in the Ross classification scheme just adds into the rest symptoms, again, issues with feeding, grunting, diaphoresis. As physicians, what do we look for when we define heart failure by symptoms? If you think about heart failure or the heart simply from a plumbing perspective, if the pump is not working, you can have problems with forward flow, getting blood to the body. But just as importantly, there's backup of flow, so what is going on the receiving side of the heart or the venous circulation. So as clinicians, we look first for signs of venous congestion, and if any of you have heard me talk about this, I'd actually, if I had a choice between a stethoscope and my hand in a patient with heart failure, I would always take my hand because I use it to feel the liver. And in a patient with systolic heart failure, as well as diastolic heart failure, patients will often have venous congestion, which is most easily found by palpating the liver. Because the liver is directly connected to the heart, any congestion in the heart will back up into the liver. Shortness of breath or rapid breathing, that usually is from backup of flow into the lungs, leading to pulmonary edema. Quote-unquote issues with eating. A very nice study several years ago from Texas Children's Hospital actually looked at what was the most common presenting symptom of heart failure in the pediatric emergency department, and found that gastrointestinal complaints were among the leading symptoms that were the kind of the cardinal or first sign of heart failure. This relates to congestion of the vascular circulation supplying the intestine. And so many patients who have heart failure as children, the first sign will be eating issues, and it can be a whole host of from constipation to indigestion to vomiting to just not wanting to eat at all. Edema is actually less common, so swelling of the extremities, particularly in younger children, but we do look for this under the venous congestion side. And then on the outward side of the heart, the systemic supply of blood to the body, we look for signs of impaired perfusion, such as abdominal pain, cool extremities. So cardiologists, you'll notice, will listen to the heart, will feel the liver, and will feel the feet, kind of as our trio of exam findings. And fatigue, obviously, can be a sign of impaired perfusion. This is a nice classification scheme that the American Heart Association put together a few years ago that divides heart failure into kind of 4 categories: warm and dry, warm and wet, cold and dry. The cold and warm relate to the perfusion of the body. The wet and dry relate to the backup or the venous congestion part that I was talking about. Most patients, when they present in heart failure, are warm and wet, meaning their perfusion is maintained, but it's the congestion that predominates. Patients who may have cardiomyopathy but don't have heart failure are what we consider warm and dry. The patients who are most concerning and need ICU management are those patients who are cold, who have impaired perfusion, and dry. Sorry, I'm still finding the best angle to click this. Here's a kind of a schematic of kind of the progression of heart failure management and how we escalate therapies. Patients who have mild symptoms ranging from severe symptoms. We have diagnosis on the top where we monitor growth and development. We follow echo, MRI, blood testing, exercise testing, EKG, and Holter. These are familiar outpatient tests that many of you have experienced. And as symptoms progress, we start thinking about evaluation for heart transplantation. Our treatments, which I'm going to go into more detail below, medical treatments here, and then we get into, as symptoms progress, into devices, mechanical support, ventricular assist devices, and again, heart transplantation. The building blocks of medical therapy, I'm going to go through in a little bit of detail here. The classes of medications that we use start off with diuretics, go through ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, digoxin, and inotropic agents. I highlighted the three classes of medications here that have been shown through adult studies to improve survival, which arguably is the most important outcome in heart failure. Have been shown to improve survival in heart failure. The other medications such as diuretics, digoxin, and inotropes are very important but have not been shown to improve survival. We use these medications, ACE inhibitors, beta blockers, mineralocorticoid receptors, not only to improve function, but most importantly as what we call reverse remodeling agents. And I'm going to discuss what reverse remodeling is in a bit more detail. What are our goals of medical therapy? Most important, 1, 2, and 3 are to relieve symptoms. We want to make our patients feel better. We want to obviously minimize risk of arrhythmias and sudden events. Reverse remodeling is very important. I put in smaller font to make you hard to see, but these tend to kind of come up a lot during visits. Improving the BNP and improving the echo. These are nice if we can get there, but not necessarily the primary goal of our treatments. And that, in as much as it can be frustrating for families, it can be frustrating for us if you're treating a patient. The echo may not be better, but the patient's feeling better. That is our most important thing, is the patient feeling better. That being said, we do a lot of echoes. Echo, when the systolic function is depressed, the improvement in the echo almost always lags behind the clinical improvement of the patient, often by many months, if not years. We do follow ejection fraction very carefully, with a normal ejection fraction being anywhere between 50 and 55%. Classically, we're taught in medical school that an ejection fraction of 55 and over is normal, but the American Heart Association actually defines an ejection fraction of 50% and higher as normal. You'll sometimes hear us talk about 50 to 55 being so-called low normal. I don't love that because it's either normal or it's not. We also, for patients with dilated cardiomyopathy and left ventricular non-compaction, pay a lot of attention to the dilation of the left ventricle and is that changing over time. Biomarkers, there's been a lot of talk about biomarkers so far, so I won't belabor this in too much detail. We define biomarkers as any measurable factor that circulates normally in the blood that yields not only diagnostic information, but some information about prognosis. The most common ones that you all are familiar with likely are the BNP and the proBNP, but other important biomarkers include troponin, ST2, galectin. All of these correlate in general with prognosis in heart failure, but it's not clear that chasing a perfect or ideal biomarker value improves outcomes for patients. And there are a lot of adult studies that have looked very carefully at this, and we can talk about later if we have time. So let me get back to reverse remodeling, because I find this an area, at least with our medical trainees, that this can be an issue of confusion. What is remodeling? So remodeling in heart failure is a bad thing, unlike in your kitchen where remodeling is good. Reverse remodeling is what we actually want. So remodeling is the process by which any negative stimulus to the heart, whether it's ischemia, viral infection, a mutation in a sarcomeric protein, leads to a number of negative processes on the cellular level. You can get fibrosis or scarring, hypertrophy or enlargement of the heart muscle, loss of heart muscles. This usually leads to a phenotype or a clinical presentation that usually results in dilation of the ventricle, thinning of the ventricular wall, and eventually dysfunction of the heart. And so our medications, beta blockers, ACE inhibitors or ARBs, and aldosterone antagonists like spironolactone are trying to reverse this process. So that's what we call it, reverse remodeling. Let me move on to ventricular assist devices in the last few minutes here. Many patients with cardiomyopathy and heart failure will not require VAD, so I hope that by bringing this up, I'm not implying that all people who have heart failure or cardiomyopathy will need a VAD, but it is an important part of our medical and surgical management. We think about VADs when patients have persistent heart failure symptoms despite what we call maximal or optimal medical therapy. Patients who have progressive decline in their clinical status. We follow very carefully the so-called end organs, so the receivers of the blood's cardiac output, including the kidney. So we follow the creatinine for kidney health, the liver, which we follow through the bilirubin. And rarely a patient who has an acute collapse and is needing ICU management, we may need to consider ventricular assist devices. I'm going to skip over this just in a matter of time. We have a classification system for how sick people are before going on VADs, but I'm going to skip over that in the interest of time. VADs are not for everybody. The classic VAD recipient is somebody with dilated cardiomyopathy. We can use them in other patients with cardiomyopathies, but they have their challenges. Patients with hypertrophic and restrictive cardiomyopathies are often not ideal candidates for VADs because their heart chambers are not enlarged. Patients who have significant right heart failure are not necessarily good candidates for VAD support unless we consider supporting not only the left ventricle but as well as the right ventricle, so-called biventricular support, which is associated with more complications. Patients who have congenital heart disease and a Fontan circulation can be supported with VADs, but often are very challenging to support. And there still is a great need for supporting small patients, less than 10 kilograms or 25 pounds. Most devices we have are adult devices that we kind of shove into small kids. We do have some devices available, but for the smallest patients, less than 5 to 10 kilograms is still a relatively unmet need. We think about, in terms of devices, we have different categories, whether the device is paracorporeal outside the body or intracorporeal inside, whether it pumps like a heart or flows continuously, and whether you use it temporarily or durable over a long term. An example of a temporary device is ECMO. An Impella is a device that can be placed temporarily through a blood vessel in the leg inside the heart. The Berlin heart, which is shown here, is the currently only widely available device that can be used in babies and is a paracorporeal outside the body pulsatile device. Newer generation devices such as the HeartWare and the HeartMate are implanted inside the heart and are considered durable devices. How do we use these devices? We typically use the phrase bridge to something. Ventricular assist devices can be used as a bridge to transplant. We can use them as a bridge to so-called decision for a person who we may not be sure is a candidate for transplant, but we want to rehabilitate them and get them in good shape for a transplant. We may have hope that the heart will recover from whatever caused the heart failure, that the heart is recoverable without transplant. Or destination, where we're thinking about a long-term support with the device without transplant. We don't use that particularly commonly in pediatrics. Finally, heart transplant in children still remains the definitive therapy to cure heart failure, if you will. But I use the word cure with a lot of caution because one could argue that it's really not a cure. That being said, it is really the one therapy that we know can provide excellent quality of life for patients with what we call end-stage or severe heart failure. There are limitations such as limited availability. There is a 1-year mortality risk of up to 10 to 20% in some patients. The heart often does not last the 60, 70 years we hope for in a child. And as we say, it trades one disease for another. And I think I will wrap up there, except in new directions, just in the last minute here. In the last talk earlier, Entresto is one of the exciting new avenues for treatment of heart failure in children. It's really one of the new classes of medications that have been brought onto the market within the last few years to treat heart failure. You've learned a bit about gene therapy for cardiomyopathy, such as Duchenne and Danon disease. The Pumpkin trial is a trial of a new novel ventricular assist device for infants with severe heart failure the size of a AA battery, which is being trialed at some centers. And the Berlin Heart VAD, which I showed you earlier, classically has not been able to be discharged to home. These patients remain in the hospital. There is now a device that can allow children to be discharged home with a VAD with the Berlin Heart, and that's going to be coming to clinical studies within the next year or two. So I thank you for your attention. I think I've run out of time, and so the group will offer my email address or contact information if you have any questions. And so it's my privilege next to introduce Danielle Burstein, who's going to talk about exercise in cardiomyopathies. Danielle, we are lucky to have hired her on staff here at CHOP within the last year. She did her pediatrics residency in Stanford, came to CHOP for fellowship, and we are lucky to keep her with us, and I'm going to introduce her for the next talk. Thank you.